Today's topic is pathophysiology of patients with congestive heart failure. Coming to the definition, heart failure describes a complex clinical syndrome where the heart is incapable of maintaining a cardiac output that is adequate to meet metabolic requirements and accommodate venous return. It carries 50% 5-year mortality rate, and prevalence is over 22 million people across the globe. Coming to the etiology, heart failure is caused by a loss of a critical quantity of functional myocardial cells after injury to the heart from a number of causes. The most common etiologies are ischemic heart disease, hypertension, and diabetes. Less common but important causes of heart failure in order of decreasing prevalence are cardiomyopathies, infections may be due to viral myocarditis or Chagas disease, and toxins may be alcohol, cytotoxic drugs, valvular heart disease, and prolonged arrhythmias. Coming to the signs and symptoms, the signs and symptoms of heart failure are the result of the clinical sequelae of inadequate cardiac output and lack of efficient venous return. Dyspnea, cough, and wheezing result from increased pressure in the pulmonary capillary bed due to ineffective forward flow from the left ventricle. Lower extremity edema as well as ascites occurs when the right ventricle is unable to accommodate systemic venous return. Fatigue is common as the failing heart cannot sustain enough cardiac output to meet the body's metabolic needs and conserves blood flow to the heart and brain. Nausea and lack of appetite may also occur as if blood is shifted from the gastrointestinal tract to the more vital organs. Palpitations can occur as the failing heart tries to accommodate for the lack of flow with a faster heart rate. Coming to the disease progression, the disease progresses through 4 main stages which are classified as stage A to stage D by American Cardiac Association or Heart Association. Coming to the stage A, in this the patients are at high risk for developing heart failure with no structural disorder of the heart, whereas stage B, patients with structural disorder of the heart without any symptoms of heart failure, whereas stage C, patients with past or current symptoms of heart failure associated with underlying structural heart disease. And lastly, stage D, patients with end-stage disease who requires specialized treatment strategies. Stage A corresponds to pre-heart failure, stage B to NYHA class 1, stage C to class 2 and 3, and stage D to class 4 heart failure. This 4-stage classification scheme underscores the principle that therapeutic interventions before the development of left ventricular dysfunction can result in a reduction in morbidity and mortality from heart failure. Coming to the pathophysiology, before going into the heart failure, this is how normal cardiac output is maintained. The main determinants are stroke volume and heart rate. And stroke volume is determined by preload, afterload, and contractility. Also, synergistic LV contraction, wall integrity, and valvular competence also aids in cardiac output maintenance. Now coming to left ventricular dysfunction. Left ventricular dysfunction can be divided into 2 categories. Systolic dysfunction, that is impaired ventricular contraction and ejection, and diastolic dysfunction, where impaired relaxation and ventricular filling takes place. This is how LV dysfunction is categorized. The EF will be less than 40. There may be volume overload, pressure overload, or loss of myocardium and impaired contractility. These all contribute to LV dysfunction with low ejection fraction. This leads to increased end systolic volume, increased end diastolic volume, pulmonary congestion. And this leads to decreased cardiac output and hypoperfusion of the vital organs. Coming to the right ventricular dysfunction, the most common cause of right ventricular failure is left ventricular failure. As the RV fails, there is similar increase in the amount of blood in the ventricle, which in turn leads to elevated right atrial pressures and increased pressure in the vena cava system, which impairs venous return to the heart. Coming to the common signs and symptoms of RV failure, The symptoms are abdominal, there will be abdominal pain, anorexia, nausea and bloating. Signs will be peripheral edema, jugular vein distension, abdominal jugular reflex and hepatomegaly. Coming to the compensatory mechanisms, mean arterial pressure is closely regulated and defined as the product of cardiac output and a total peripheral resistance. A patient with heart failure has decreased cardiac output, which in turn leads to a decrease in mean arterial pressure and therefore decreased tissue perfusion. The body thus tries to maintain adequate tissue perfusion and compensates to bring MAP back to normal using several mechanisms including Frank-Starling mechanism, neurohormonal activation and ventricular remodeling. While initially beneficial, the long-term effects of these mechanisms serve to worsen heart failure in a vicious cycle. Coming to the Frank-Starling mechanism, here you can see the x-axis shows left ventricular end diastolic pressure or diastolic volume, on y-axis shows stroke volume or cardiac output. This represents that cardiac function or cardiac output as a function of LV-EDP, which is directly related to left ventricular end diastolic volume. And as you can see, point A is on the curve, which represents a healthy patient with normal heart. On this curve, as preload, that is LV end diastolic volume increases, this leads to an increase in the left ventricular end diastolic pressure, which causes a stretch in the myocardium, which responds with an increase in cardiac output, which is known as the Frank-Starling mechanism. As you can see now, coming to point B and C are on the same another curve, which represents a patient with systolic dysfunction. This curve is below that of a normal heart because the failing heart is unable to contract as it once did, and thus stroke volume fails and there is stroke volume fails to increase and there is an increase in left ventricular end diastolic volume, that is preload. Initially at this point, that is point B, which is on the ascending portion of the curve, this increase in preload leads to compensatory increase in the cardiac output, although there is less impact as similar increase in preload would have on the normal heart, as this in a patient's heart failure increase as indicated. Continued progression of the heart failure eventually leads to critical reduction in the blood flow to all the vital organs. In this final phase, the body maximizes all its vasoconstrictive mechanisms in an attempt to redirect blood flow to these critical organ systems, which only adds to the hemodynamic burden of the failing heart. Thus, ventricular function progressively deteriorates and terminal heart failure ensues. This as vicious cycle develops, the end result will be progressive ventricular dysfunction and death. As you see in the figure, left ventricular dysfunction leads to decrease in the cardiac output and decrease in the blood pressure, and the mechanisms, compensatory mechanisms such as Frank-Starling mechanism, ventricular remodeling, neurohormonal activation will start, and this causes increased cardiac output and increased blood pressure because of vasoconstriction and increased blood volume, and this leads to increased cardiac workload because of there will be increase in preload and afterload, and this in turn again exacerbates LV dysfunction. This is the vicious cycle. Coming to the assessment of the patient with heart failure, begins with documentation of the history of heart failure, symptoms, performing a physical examination and obtaining laboratory and other diagnostic tests to ascertain the severity of the disease. The type of cardiac dysfunction, whether systolic or diastolic, should be established, and the etiology should be determined to see if this is a reversible process or not. With this information, patient can be provided with both a prognosis and an appropriate treatment plan. Coming to the basic guidelines put forth by American Heart Association, these are grouped staged into 4 from A to D. Stage A is patients with high risk, with no structural heart disease, and the therapy primarily focused on the management of hypertension and lipid disorders, encourage regular exercise and discouraging alcohol intake and ACE inhibition. And patients with stage B, that is, there will be a structural heart disease, but patients are mostly asymptomatic. In this, all the measures which are taken in the stage A should be continued along with ACE inhibitors in appropriate patients and beta blocker in appropriate patients. In stage 3, there will be structural heart disease with prior or current symptoms of heart failure will be seen. In this, all the therapies under stage A should be used, and the drugs mainly in this stage are diuretics, ACE inhibitors, beta blockers, digitalis and dietary salt restriction. Coming to stage D, refractory heart failure requiring specialized interventions. In this, all the medications and therapies from stage A, B and C are being used, and still the heart failure is progressing. So, mechanical assist device will be used in this stage, and finally heart transplantation is the goal, and also in palliative care, that is hospice care also may be advised. Coming to the general measures for the treatment of heart failure, mainly divided into lifestyle modifications and medical therapy. In lifestyle modifications, weight reduction, smoking cessation, avoidance of alcohol and exercise are to be done. And in medical therapy, treatment of hypertension, hyperlipidemia, diabetes and arrhythmias, coronary revascularization, anticoagulation and immunization, sodium restriction in daily weights and close outpatient monitoring should be done. Coming to the outcomes, in a study conducted in the Lancet Global Health, the all-cause mortality is up to 2 to 4% at 30 days and 13 to 7% at 1 year and 28.2% at 3 years after discharge. Most of these deaths were attributed to cardiovascular disease, and decrease in ejection fraction was associated with an increased mortality risk. The evidence that guideline-directed medical therapy reduced overall cardiovascular morbidity emphasizes the importance of monitoring and improving the quality of heart failure management at a national level. Thank you.